Hello everyone. Sorry I'm just now recording this video. My child is finally asleep at a decent hour, so all is quiet in my house, and I can finally awkwardly record my presentation for you all. Before I get started, I wanted to specify that today I'm only going to be talking about OCD in adults. OCD obviously has its onset in childhood in some cases, like depending on its etiology, but I just wanted to specify that the assessments and measurements that I'm talking about today are going to only be applicable to adults. So let's go ahead and get started. So before I get into the DSM criteria of OCD, I wanted to talk a little bit about its historical background, primarily because I find it interesting how our conceptualizations of mental illness change over time. So in the 15th century, there's an interesting account of a priest who compulsively sticks his tongue out anytime he sees like a female form, like in a statue or a painting, and that was documented in the Malleus Maleficarum, and they attributed his behavior to Satan. So I don't know if you're familiar, but kind of in the early days of civilization, mental illness was always kind of attributed to like satanic possession, which is interesting. In the 17th century, that kind of shifted, and OCD was recognized as a religious melancholy. So again, we kind of have this religious component to it, this morality component, which we'll talk more about later. And then also it was at this time that Shakespeare, in his play Macbeth, he wrote about a character, Lady Macbeth, who has a hand-washing ritual. So I thought that was interesting that OCD was kind of documented in literature in that way. And then in 1838, OCD was described as a monomania, which is partial insanity, and it was described as a disease of the will. And this is also something that changed across history. Initially, it was kind of a disease of the will, and physicians at the time kind of disagreed about whether it was an emotional disorder, a disorder of the intellect, or the disease of the will. So in the 1850s, the pendulum kind of swung, and it was understood as an emotional disorder. And in 1868, German psychiatry was like, no, it's obviously a disorder of the intellect. And in 1877, Westphal gave his account, and he talked about OCD or OCD-like symptoms as a compelled presentation or idea, and I'm not even going to attempt to butcher this word here, but that's kind of significant because that's kind of how we think about obsessions and compulsions today. And in the 20th century, Pierre Janet described what he termed psychasthenia he described two cases in young children. Again, this is significant because OCD typically has its onset in middle childhood, but also the term psychasthenia is something that we still see today in the MMPI too. And then in 1909, of course, Freud gave an account of this in The Rat Man. In Freud's view, the patient's mind kind of responded maladaptively to conflicts between unacceptable, unconscious, sexual or aggressive impulses and the demands of conscious reality. So it was kind of this conflict between these unacceptable drives and everything else, and so the ego would kind of put forth these defenses, and and if they were unsuccessful in Freud's view, this would give rise to OCD symptoms. If you have, spare time and something's keeping you up at night, I highly suggest looking at Freud's Rat Man case. It's both fascinating and disturbing. So The 1950s saw this rise of behavioral therapy, and these learning theories were extremely helpful in the treating of phobic disorders, so they were applied to OCD symptoms because there are like some commonalities there. And we'll talk more about that when we talk about the treatment of OCD. And then in the 1980s, that's when we began understanding OCD as having a neurological component. So sorry for kind of the wall of text here, but this is the DSM. Oops. This is the DSM criteria. I don't know if you can see it all, but so like as you know, OCD has two components: obsessions and compulsions. And obsessions have to be present. There are just kind of pure obsession disorder, but that's very rare. And obsessions are defined as recurrent and persistent thoughts, urges, or images that are experienced at some time during this disturbance. They are intrusive, unwanted, and they cause the individual a fair amount of distress and anxiety. And also what's important here is that the individual attempts to ignore and suppress these thoughts, or they try to neutralize them with compulsions. So compulsions are defined as repetitive behaviors or mental acts that the individual is, again, compelled to do because of these obsessions. And engaging in the compulsions helps reduce the anxiety caused by the obsessions. And and kind of the aim of these behaviors is to prevent, so say they're obsessing about contamination and germs, so the compulsion there is related because they are washing their hands to avoid being contaminated. So the behaviors and mental acts are aimed at preventing or reducing anxiety or distress, or like preventing the dreaded event from taking place. So the obsessions and compulsions must be time consuming. They must take up more than 1 hour of the individual's day and cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. A lot of times individuals with OCD, their compulsions take up so much of their day that they're unable to work. So there's occupational functioning there. But also, social functioning can be impaired because they will ask individuals in their day-to-day life to kind of assist them in these compulsive behaviors and their rituals. So obviously that can put a lot of strain on individuals' relationships. And criterion C, the obsessive compulsive symptoms are not attributable to the physiological effects of a substance or any other medical condition, and the disturbance is not better explained by the symptoms of another mental disorder. So when you're making this diagnosis, you must specify if they have good or fair insight, and what this means is that the individual is capable of recognizing that the beliefs are probably not true, or they recognize their obsessions as being kind of irrational. With poor insight, the individual thinks that their beliefs are most likely true. They're definitely true. And then absent insight or delusional beliefs, the individual is completely convinced that obsessive compulsive disorder beliefs are true. And again, when we're talking about making this diagnosis, this is going to have some implications for the assessment tools that we use. And then you also must specify if it is tic related, so if the individual has a current or past history of tic disorder. So some common features, again, obsessions are mental events, whereas compulsions can be an overt behavior or a covert mental ritual. So the obsessions are definitely mental, but the compulsions can be kind of either or. And the covert mental ritual, an example of that would be like prayer, or perhaps like counting mentally in your head, or silently to yourself. So the aim of the compulsion is usually to reduce obsessional distress or prevent harm associated with the obsession. 90% of individuals with OCD manifest with both obsessions and behavioral rituals. As I mentioned, it's pretty rare for an individual just to have pure obsession disorder. So some common themes with obsessions are causing harm to others, like hurting children or hurting family members, or having like a parent die. Contamination is also common, and doubting whether one locked the door. So then the compulsions that are aimed at like reducing anxiety from these obsessions are like checking, hand washing, counting, things like that. The 12-month prevalence of OCD in the United States is roughly 1%, so it is a bit rare. Internationally, it's very similar, and we'll talk about this more later when we talk about OCD across cultures, but it's pretty much the same rates worldwide as it is in the United States. Females are affected at a slightly higher rate than males in adulthood. However, the age of onset is different. So for males, the onset of OCD occurs much earlier, whereas like from ages 13 to 15, whereas females' onset typically occurs between the ages of 20 and 24. So the onset of symptoms is typically gradual. So they slowly start to exhibit symptoms. They become more preoccupied with certain thoughts, and then that kind of increases, and they become more these kind of what were preoccupations become obsessions, and it's kind of all they can think about. And then they start engaging in behaviors or mental acts. And then acute onset, so when obsessive and compulsive symptoms start occurring immediately, that is typically associated with PANDAS. And PANDAS, as I said, is like I want to say it's like a viral, or maybe it's an infection. But that typically occurs more often in kids. So individuals with OCD usually suffer for many years prior to seeking treatment. On average, they go for about 7 years with significant symptoms before they seek help. Marital distress is reported by approximately 50% of married individuals seeking treatment for OCD. As I mentioned, lots of functional impairment in terms of their social relationships, and then also disruptions in gainful employment, social functioning, and interpersonal relationships. OCD rarely occurs in isolation. 76% of individuals with OCD also have anxiety disorder, or 63% have a mood disorder. It's more likely that mood disorder is MDD. 30% have a lifetime tic disorder, and again, specify when you're making this diagnosis, specify if tic disorder is also present. 12% prevalence rate in individuals with schizophrenia and schizoaffective disorder, which again I thought was very interesting, because schizophrenia also has a huge neurological component, as does OCD, so maybe that's related. It's possibly a future direction for research. OCD is typically the principal diagnosis, and what that means is if it is comorbid with something like MDD or GAD, OCD is the diagnosis of greatest severity, meaning it's causing the most functional impairment. The relationship between comorbidity and the severity of OCD symptoms is unclear. They're not really sure if having MDD or another anxiety disorder exacerbates OCD symptoms, but what they do know is that comorbidity is associated with poor quality of life, particularly in comorbid depression. High levels of depression prior to treatment are related to poor treatment outcomes. So